Good afternoon, everyone, and welcome. We are going to give everyone a couple of minutes to log on and get settled, and then we will start. Good afternoon, everyone. Welcome. We are still having participants flow in through the great gates. So we'll wait another couple minutes to let everyone get in, and then we will get started. All right, we are at 2 after the hour, so I will get started. Welcome, everybody. Good afternoon. We are here to discuss the current and future state of digital health credentials. We want to thank our generous sponsor and friends at IBM Watson Health. I am Alice Leiter. I'm the Vice President and Senior Counsel at Executives for Health Innovation, formerly the eHealth Initiative, still tripping over the new name. But I am delighted today to be joined by a veritable brain trust of illustrious speakers. We have Dr. Sunil Budrani, the Chief Executive Officer and Chief Medical Officer at Innovation Health, who will be our moderator today. Eric Cassini, the Global Vice President of Payer and Emerging Business Networks at IBM Watson Health. Quentin Paulfrey, who's the President of the International Digital Accountability Council, or IDAC. And Gautam G. Shah, who's the Vice President of Platform and Marketplace at Change Healthcare. Just a little bit about Executives for Health Innovation. We're a membership organization striving to catalyze healthcare transformation with a focus on innovation and diverse perspectives. We are small but mighty. Here is a layout of our staff. It's amazing what just a few women and one fantastic male can do. Our 3 main areas of work are in education, advocacy, and thought leadership. Our focus areas change as the healthcare landscape changes. Currently, our main focuses are on social determinants of health, SDOH, virtual care, consumer privacy of health data, and COVID-19, as everybody is focused on best practices and areas for innovation. I will certainly not read these. This is a representation of our membership. You can see it's a fantastic and diverse group of organizations. We have also terrific leadership council. These names are available on our website if you'd like to learn any more about our membership or the leadership council. And I just wanted to do a little bit of housekeeping. We will keep everybody muted other than our panelists. We will hope to leave time at the end of this discussion for questions and answers. Please type them into the Q&A box. And we look forward to a fantastic discussion. So with that, I'm going to stop sharing my screen and turn it over to Dr. Budrani, who's going to lead our discussion today. Thank you all for joining us.
Hi, everyone. Hope you're well as we are getting, it's amazing as we look through the year, how fast it's gone and already into December. So hope your families, friends, and everyone is doing well these days and keeping yourself well. I always say we can't keep others well if we don't do for ourselves the same. So it's a pleasure to be here. As mentioned, my name is Sunil Budrani. I'm the CEO and Chief Medical Officer of the CVS Aetna and Inova joint venture known as Innovation Health in the DC metropolitan area. I oversee the operations of our commercial Medicare and individual exchange health plan, as well as I oversee our medical management solutions for the region. We are a collaboration between CVS Aetna and Inova Health System, which allows us to bring together a number of medical management opportunities, member differentiation opportunities, technology opportunities, which we'll touch on in this conversation, between a retail pharmacy, an insurance company, and a major health system. So the topic that we're going to be talking about is actually one that's near and dear to me, as I'm very curious to get the input of the expert panel that we're going to be asking these questions to. I always joke, that's my day job. I spend my evenings and weekends for the last several years as an ER physician. I'm a clinical associate professor of emergency medicine at George Washington's School of Medicine, where I did my training. And I can tell you, practicing more than 20 years now, there's never been a more profound time that I've practiced as a physician than the last probably 19 months. Understanding, sympathizing, and really appreciating not just the staff and all the people that have been working through these difficult times, but also understanding how different technologies, different workflows, and different opportunities, and thinking about ways we can manage our patients, our members, and the community better have risen to the top in a way that I can't appreciate in all the years that I've practiced than I've seen now. So digital health credentialing, which we're going to talk about, is an area that's gained a lot of importance and attention, especially, again, during these times. And how do we take people and manpower to take care of patients, but bring in other digital assets to provide better care, is something that I look forward to as the pandemic continues to play out and what opportunities are there. But also, how do we complement the existing healthcare system and make it better from what we've learned in the last 19 months? So that being said, I'm happy to moderate the panel today, and I'll turn it over to the other panelists to provide an introduction, and then we can get to the heart of the question. So I'll lead this. Eric, can you please go ahead and introduce yourself?
Yeah, thank you very much, Sunil. Eric Piscini. I lead what we call Global Emerging Business Networks for IBM Watson Health. And what it means really is we are launching new platforms, solutions, and products for the healthcare and life science industry. We've been doing that for about 2 years now. We have many different solutions. One of the solutions that we launched recently is Digital Health Pass, and we'll talk about that today. I just wanted to say thank you, Sunil, for everything that you do for helping everybody in this country and around the globe to go through that pandemic. And, you know, unfortunately, I don't think it's over anytime soon. And then thank you to EHI for organizing this. We are really happy to be participating in this conversation and supporting EHI and its members. So thank you for having me and looking forward to the discussion.
Great, and thank you. G, Gautam?
Everyone, G Shah. I lead the digital transformation practice at Change Healthcare, which includes rethinking about how we deliver healthcare products and services to the broader healthcare ecosystem and really expanding our ability to get the goodness that is healthcare operations, healthcare financial, and clinical operations out into the world. A big part of that is rethinking how we drive access to data and how we make data more ubiquitous to everyone. And as we all know, vaccination data and digital health data is just on the starting point of being available to everyone more broadly. And with that, it has raised some interesting challenges. So as we've launched our vaccine record product, which serves a fairly broad footprint across all 50 states, we've come to realize that there is a need for healthcare data interoperability, not just at the clinical level, but at the vaccination level, at the testing level, and everything else, so we can empower patients, as Dr. Badrani said, to actually take better care of themselves and the people around them. So looking forward to the conversation today and talking a little bit about that. And again, thank you, EHI, for the opportunity to participate.
Great. Thank you, G. Quentin?
Hi, thanks so much for having me. I'm thrilled to be here. Thanks to IBM, thanks to EHI. What a terrific panel this is. My name is Quentin Paulfrey. I lead an organization called the International Digital Accountability Council, which is a relatively new nonprofit consumer protection organization that is focused on increasing trust in the digital ecosystem. I come at this as a lawyer with a long background in public policy and consumer protection. I was the chief of the healthcare division in the Massachusetts Attorney General's office. I was in the Obama White House as senior advisor for jobs and competitiveness, working on some of the work to build a consumer privacy bill of rights and some of the work around the Blue Button initiative, which we can talk about a little bit in terms of health data portability. And most recently, I was the acting general counsel of the Commerce Department in the Biden administration. So I've had a couple of tours in government, but the work that I focus on now is consumer protection issues in this digital space. And just sort of broadly, I'd like to focus on both the transformative possibilities of this space. I think that there's just an enormous amount that we can do with personalized digital medicine, and also the importance of having clear rules and trust in order to unlock that transformative potential. So I'm really excited about this conversation.
Great, thank you. And as you can see, we have a very varied background in a very important conversation about digital health credentialing and interoperability. So should be very insightful to understand everybody's angle from the point of view on this really important topic. I always say that there's this debate about whether the US healthcare system is truly one of the best in the world. And I like answering kind of that debate or thinking about that debate in this way. There is, in my mind, if you have a very invasive type of cancer, you have a heart attack, you have a stroke, our healthcare system will pull out all the stops and what I call throw the kitchen sink at you. We will do everything and anything. And as doctors, we are trained to save life at any cost. We'll figure out the cost part later. And it's very interesting how we have this kind of reactive approach to disease and healthcare. And if somebody has a condition like diabetes, we will do everything for them. And I think we've learned a lot during the pandemic where the proactive nature that needs to be a part of our US healthcare system has been lacking. It's something we've known for a very long time in healthcare, that if we invested the same amount of resources before the person has a stroke, before they have heart disease, depression, we can make a lot of impact than after. And clearly, as I said, with the pandemic, our interoperability, our public health, our preventive systems were not integrated to be able to address a viral spread that we were dealing with very early on. We didn't understand how the virus worked. We didn't understand how it spread. We didn't know how to manage testing, and we couldn't coordinate all testing and vaccine very well in the beginning of the process. So what I would ask you all is, how do you think that digital health credentials can help in this kind of prevention of disease, this proactive view of healthcare that we should have rather than this reactive view, and also help address the current crisis as an opportunity to grow and change our healthcare system? So if somebody wants to raise their hand, or I'm happy to call on and be the first to respond, that would be great.
Yeah, I can start. Sunil, thanks for the question. I think the way we looked at it when we started working on this platform that we have, which is really a credentialing platform for medical information, we looked at it three different ways. One, technology. We are IBM, we are a technology company. Two, we looked at it from a privacy point of view. And the privacy was extremely important for us because that notion of trust that you need to associate with any tool that you use consuming or exposing your health data has to be there. So that notion of trust around privacy was extremely critical. And then the third dimension, which I think touch on your point about being proactive about the future, is education. And the best way for us to contribute to that education was to actually say to individuals, you now have a chance to engage with your own data and to be smart about your own data through this platform. And because you do that, you might be able to yourself be proactive about your own health or share information with third parties who can help you be proactive about your own health. I think those were the foundation of our platform. And that's really why we are really excited with this platform, not just for COVID-19, but for the long trajectory of where we are here, which is digital credentialing is a way, an avenue, a channel for individuals to regain engagement and excitement about their own data, their own medical data, their digital drone, digital clone, sorry, not drone, digital clone is what we talk about here. So that's really important to us. That was one angle that we used during this journey that we had. And I'm sure G, by the way, I call G my pandemic friend because we met during the pandemic.
Yeah.
And we worked together, we partnered together on a lot of topics. And so I'm sure G has very similar or maybe new point of view on that too.
No, thanks, Eric. I mean, yeah, I think our thought processes are aligned. You know, the one thing we think about is, you know, healthcare is a team sport, right? It's not just the patient, it's not just the patient's doctor. There's people around them, and the thing that really powers that team sport is data. And to this point, we as patients, right, as patients or as members or, you know, broadly healthcare consumers, we've never really had this opportunity to get our data in our hands to help with the prevention, with the broader base of our healthcare, only because it's always been locked up someplace. Mm-hmm. And so as we think about making data more available, putting it into the hands of the consumer, putting it into the hand, you know, giving it, letting that consumer share it with the people they want to, you start to open the aperture of how you can take care of yourself and how you can share that data with other people to help you care for yourself and be more preventative. But as you all said, this lies in therein lies a problem. Who are you giving this data to? How do you know that it's going to be used properly? How do you know you can trust them? And, you know, we think about this in two ways. From the perspective of vaccinations and testing, unfortunately, we know there's fraud in the system. You know, there's any number of news stories that have come up recently where, you know, 60,000 fully filled out, very high quality fake COVID vaccination cards landed on a dock in San Diego. Well, that's 60,000 people walking around claiming to be vaccinated that may not, which is an impact to the health of the population. On the flip side, and we see this often, and I think we've all experienced this as consumers, we've all gone to our doctor's office and said, hey, I want to share with you my healthcare data. And our provider said, well, that's great, but how do I know this is real? How do I understand its provenance? Is it trustworthy? And so we have to solve both of these problems, these problems of trust, the problems of purpose of use, and the problem of privacy. And the last point I'll make here is it only gets worse when we walk out into the digital health ecosystem, because we know that's where innovation happens. So I want to be able to share my healthcare data with other applications that might help me with a chronic disease, that might help me with wellness, that might help me take better care of myself. But how do I know? How do I know if I should do that? And how do I trust them? I'm sure, Quentin, you've got a perspective on that.
I do. Thanks so much, G. I mean, so I think as with so many things, the pandemic has supercharged a lot of questions that we were already working on more broadly. So as Sunil was talking about, there is an enormous potential for the use of digital information about ourselves to help us manage chronic health conditions, to help us work with our doctors and work across the health ecosystem if we can give patients access to that information and design a trusted system for interoperability. And I think that could help with Sunil's question about how we can ensure that the US healthcare system gets more preventative and deals with issues like racial equity. Some of the most significant racial disparities in our healthcare system relate to chronic disease conditions like diabetes or obesity, and where the access to these records and this information and interoperability, putting that into our hands could really transform the tools that we have available that our healthcare system and that our individuals have at their disposal. The problem is that you don't trust it. And there's good reason for that. Our regulatory system, our legal system has not kept up with the transformations in the digital space. That's true in general, and that's true with respect to health data. A lot of the rules that were put in place to make people feel confident that when they interact with medical professionals, those data would be treated in a trustworthy way, come from an analog era. And are not actually germane when you're using apps, when you're using your fitness devices, and don't really apply. So what does apply is a patchwork set of rules that are both outdated and not specific to the digital health space. And so one of the challenges that we have as we're trying to innovate with any number of COVID-related digital health tools, credentials, but also tracking or quarantine enforcement, and whatever else we're trying to do, is trying to enable that incredible set of tools, but do it on the backs of a legal and regulatory system that doesn't cause people to trust. And where a lot of those business models are a poor fit for the kind of services that we should expect from these tools.
Yes, absolutely. And I like, G, you made a comment about this is a team effort, really being able to, I always say that health is not going to improve just because a patient decides or a doctor decides, or your insurance company, or an app helps you. It's a combination effort of yourself, the technology, your doctor. It's such a team effort. And then to summarize something I also heard is, it's a team effort where everybody speaks a different language. There's thousands of health languages that are spoken. The insurance companies, the hospitals, different medical record systems, the digital applications are all speaking different languages. And what I always get worried about is with the emergence of 10 apps for diabetes, 10 apps for mental wellness, are we fragmenting an already fragmented industry that speaks different languages? A great example of that is if I see a patient in the ER for abdominal pain, and I ask them, did you get an x-ray for this when you were in California? They don't know. And they're not expected to know if it was an x-ray or a CAT scan or what the test was that was really done. And so what do? I end up having to repeat it because we have a language barrier and I need to make sure I'm not missing anything. Unlike the finance industry where I can put my ATM card in California, live in DC, and get all my information from one spot. So it's not that we can't be interoperable, but the whole notion of a digital health passport, a digital health credentialing, something that's very needed, has really emerged more during the pandemic because of the vaccine card and some states wanting to do a vaccine passport. We haven't been able to get aligned on these things, and that's why we're still on paper with vaccine cards when we walk into a restaurant and so on. But what other challenges do you all think that we have? You touched on some of them. What other challenges do you think we have with digital health credentialing, thinking about it from a public sector, private sector, whatever sector point of view that lay ahead of us from really achieving a digital health compatibility or credentialing to make people be able to exchange data between providers and patients?
I think there's one issue we have to, and it's a bit of the elephant in the room, and that's the one of convenience. Right. And so, and Quentin, I really appreciate you bringing up the regulatory sphere here, because we are at that point where, because it's so hard to share, because it's so hard to verify, we default to this idea of what's most convenient, and that is show the piece of paper, right? Because everything else is so hard. And I'll give you a quick personal example. I'm here in Las Vegas at a conference, and I walked in to register, and of course I showed my digital health card that had a verifiable QR code on it, and the person behind the counter was like, yeah, okay, good enough. And the person next to me showed their paper card and it was, okay, good enough, right? That's convenience because there's so much friction in the system. So I think one of the biggest challenges we have to get over is how do we make it easy to share at the patient's control, obviously, and how do we make it easy to verify so that what's shared can actually be validated and is trustworthy? And I think the second thing is how do we make that sharing easy programmatically, right? Because at the end of the day, it's not just about whipping out your phone because not everyone has one. It's not about taking a piece of paper out of your wallet. It's being able to distribute more broadly. And how do you do that in a trustworthy and verifiable manner?
So I want to mention two challenges that I'm focused on. One is racial equity. And I think that, if you try to build a system around digital tools that may not be universally available, you always run the risk that people who are wealthy and have access to those tools will have a greater opportunity to participate in the new system. And so you've got to be worried about that. But you also have to think about the opportunities for these tools to actually mitigate the challenges that most directly hit the most disadvantaged communities. And so getting this right can also be a solution to those racial equity challenges. And I do think that that needs to be front of mind now. The other thing I will talk about is sort of underlying the question of trust is trustworthiness. And I do think that the lack of clear rules of the road for what is allowed and not allowed in terms of information sharing between a third-party application that is using your health record and anybody that they interact with on the back end is a really big gap. So there are a lot of things that are lawful in this broken kind of legal system in terms of what an app can share with third parties, whether that's precise location, whether that's simultaneously transmitting multiple identifiers that allow for re-identification on the back end, whether that's sort of sharing non-health information for commercial purposes in a way that's used for advertising or analytics. Those kinds of things we need to be pretty clear about. And we both need to sort of say, here are some of the contexts in which there need to be strict use limitations, where there do need to be certain rules for what you're allowed to do and not do. And then we need to enforce them. We need to watchdog them. We need to set out a clear rule of the road. So one of the things that EHI and CDT are doing that's great is trying to sort of help clarify some of the rules of the road more broadly in this digital health space. And that's sorely needed in the absence of a comprehensive set of rules. And that's not to say that privacy is the highest order value here. It's a very important value here, but a failure to come up with clear rules and build trustworthiness into the system can create an environment that makes adoption of these tools impossible. And then creates a drag on what we're trying to do from a public health perspective. So it's not privacy versus these tools, it's consumer protections and sensible rules in order to enable a system that works and that can accomplish the objectives that we're trying to accomplish.
Very good point. Very good point. Eric, do you want to add anything to this?
No, I was thinking, I really like what Quentin just said. I was thinking, we've been the product of platforms before, social media platforms. We don't want to be the product of digital health platform. And I think that really is the core of what we are talking about here. And I would say you have consumer protection and you have education. And we spend a lot of time on education ourselves, because I truly believe that education is something that's going to unlock the adoption of those platforms and unlock the ability for people to really engage with their own data, right? I said that earlier, but to me, that's really the end game, is to have people in better connection with themselves through the access to the data. I think that's really critical.
Yeah, and I want to dive a little bit deeper on your comments about equity. There's gender, race equities, there's differences in how healthcare disease presents in different races, different genders, and so on. And that obviously has become profound and noted during the pandemic, but it's existed since the beginning of healthcare, right? Diabetes, depression, these have been pandemics in underserved communities. Let's be honest that the coronavirus is just another example of what could be mental health disease, diabetes, hypertension that have unequally affected these communities that, Quentin, that you were talking about. And so understanding, I am seeing for the recent time in healthcare, we looked at data for years, looking at high-risk populations that incorporated frequent ER visits, frequent hospitalizations, cost of care. These were the variables. What's happened in the last 10 months is more organizations, whether they're insurance, health systems, or even some of the big digital technology giants, are looking at zip codes. I don't remember people looking at zip codes 10 years ago or 5 years ago to see where people are sicker. And this is all created and brought to attention social determinants of health, nutrition, transportation, education. So we're looking at data to see where these communities are and not necessarily putting a Band-Aid on diabetes, but diving deeper and understanding what the root cause of that illness is. So that being said, any other comments you want to make about addressing social determinants of health, inequities in these communities, to make sure that digital tools are available to this population, because we know that's the high target area that we need to address, but it's the same area we want to try to solve the problem with technology, and we know there are gaps there. Any other thoughts there?
Well, Sunil, I think what you said earlier, you were comparing healthcare to finance and banking, and I was in banking for many, many years as well. The good news, I think, here is that access to digital tools today is much higher than access to banking overall, right? So you have more people with a phone than people with a bank account, even in the US, right? So that's the good news. To your point, when we build those solutions, we need to think about people who don't have access to a smartphone, don't have access to a computer, right? How do we engage with them? And I give you an example of what we did in the state of New York. We actually came up with a solution with the state to say, we will give you access to our solution in different libraries across the state. So you can go and get access to a computer, get access to the internet, get access to your data, and be able to access your vaccine status through that mechanism. So those things don't happen in a silo. They happen because, from a design point of view, from the very beginning of the platform, we thought about equity, we thought about inclusion, we thought about access. To me, that's extremely important, and it goes to convenience. What G was saying earlier, what convenience at the end of the day is what's going to make us successful or make us fail.
Yeah, I'll just reinforce Eric's point. It is about intentional design, understanding that, and as we did with our product as well, it's not smartphone based. In fact, and Eric knows this, the funny story when we developed our vaccine record product is I had to go out and buy a non-smartphone because I couldn't find anyone that had one, because we had to go test on a non-smartphone because we know that people have them. And so how do you make sure through this intentional design process that you make that capability available to anyone, whether it's on their own device in the library, on their smartphone, on a flip phone, on a phone that doesn't belong to them, or on a device that doesn't belong to them, so they all have access. I think the other key piece of that, though, and this is what makes at least the vaccination part of this discussion interesting, is that is a very personal thing, right? Having that record is the thing that I want to carry in my back pocket to share it, but that may not always be the case. So how do we, within these underserved populations, or these populations that don't have digital access, still make it easy for them to get their vaccination information? How do we distribute that access point to the edge where it's actually going to be used? And again, that's another part of the intentional design of these products that we have to think about when we're making the data available.
Yeah, I mean, I would add that data are very helpful in making these early sort of investments in equity in this planning process. So you can't solve problems that you don't measure, and so I do think it's important that as you're designing the rollout of a new system or a new program, whether that's health credentials or some other program, you should both sort of identify equity as one of the priorities and then measure it, it and track deliverables over time so that you see whether you're actually accomplishing that as an objective. So you got to center it in the planning process. The other thing I will say is there are other spaces in which we have encountered similar challenges where we can learn from them. So for example, personalized learning, distance-based learning, and the incorporation of technology into pedagogy has some of the same challenges. As children were trying to learn remotely during the pandemic, we saw a lot of low-income populations, we saw a lot of communities of color having disproportionate barriers to accessing those systems. And so some of the solutions that we tried to put in place in some of those contexts may point the way towards possibilities in the health space, and some of them are system-wide. So in President Biden's and Congress's recent investments, we just need more broadband, right? We need to have better access to technology, and that's in some cases going to require greater investments in that system-wide, and the kinds of tools that we use to electrify rural areas and low-income areas, the kinds of tools that we have used to get cable into those communities are also the kinds of things that we're going to need to think about investing in system-wide to make sure that we are making progress over time on these digital health gaps.
All very good points. Let's talk about a side of this whole interoperability discussion, also with regards to getting the technology in the right communities, all the communities, frankly, to be able to do this kind of work is privacy. Cyber breaches we hear about in healthcare systems. Some will argue that a medical record is several times more costly than a credit card number. And I think most will argue that. So there's some significant concerns around privacy. And I use an example. I was in the telemedicine space several years ago and did a lot of work for the American Telemedicine Association on how do you do telemedicine and how do you keep it safe. And one of the challenges we would get in these conversations was, well, we can't use any video platform because it has to be HIPAA compliant and meet a higher level of requirement than a typical one-on-one video solution, whether it's a FaceTime or so on. It had to be a specific technology. Fast forward, we have a pandemic, and the technological barriers were actually reduced so that we could facilitate these kinds of visits. It was realized that we could do safe visits using the regular one-on-one encrypted technology without taking the bar so high. There's not been that many breaches that we've heard about, with millions of telehealth visits occurring during the pandemic. So I would ask you all your thoughts with digital health credentialing, sharing data, interoperability. What are some of the things that we should be considering when it comes to privacy? And obviously, I would say the public sector kind of has been straddling on how involved can it really get in creating a dictate on how privacy should be handled. And the private sector has fragmented the healthcare industry. So how do you see that playing out for this kind of credentialing to occur?
And Sunil, I think I give you a number based on what you just said. You mentioned, digital records for healthcare are more valuable than credit card data. A brand new, fresh hacked credit card number with all the information is about $200 online, right? A full LPR, longitudinal personal records, is about $30,000. So that gives you the difference between the value of those assets on the dark market. So that to me is reinforcing your question, which is privacy is going to be extremely critical. To me, we answer that three ways. One is we need standards around interoperability. We need to agree with each other that this is the way we're going to communicate. This is the way we're going to share information. This is the way we're going to trust each other, right? So we haven't talked about trust registries, but this is a very important piece of all the platforms we are building. We need trust registries. We need to make sure that when I have a vaccine record from CVS, then when I traveled to Japan, Japan actually knows that CVS is a trusted issuer of vaccine records for me, because they don't know CVS in Japan. Maybe they do, but you got the point. And that is extremely valuable. So that notion of creating standards and using the same standards together is really important. We did a lot of that, right? And G and I and many other have been working on those during the pandemic. And in the US, we have VCI. In Europe, you have DCC. You have many different standards today. That's number one. I think number two to me is that notion of today we don't have an excuse to expose data if we don't need to. We don't have an excuse. We don't have a reason, a technical reason to capture information and keep this information if we can not do it, right? So give you an example. When we create a credential for someone on our platform, we actually do not keep any information after the credential is created. So you can hack all you want out of my platform. There's nothing to hack because we don't keep any data, right? And today, if someone is building a platform that is different, they are doing it for different purposes. They are doing it because they want to turn you into a product, right? And that to me is what we need to be extremely careful about. We need to, and that's where education, number three, always education to me, is very critical. We need to educate people around how your data is going to be captured, stored, transported, and exposed when you share this information with a third party. Education. I give you a very interesting point. When we did launch in New York, almost a year ago now, we let people in New York, every resident, access their vaccine records. And one of the big pushback was the state is Big Brother because the state has my vaccine record. And everybody thought it was something new as part of the pandemic that every the state of New York was actually now monitoring my vaccination status. What people didn't know was that it's been like this in every state in the US for 25 years. But people didn't know. And so I think education is part of that too, is you have entities today, your doctor, your insurance company, states, they do have access to this information for good reasons. We need to make sure you can trust them. Other parties like us, you should not trust us by default. You should trust us because you understand how we are managing our solutions, your data.
Yeah, I see a lot of parallels between what you're talking about and what we saw with the CMS patient access and interoperability rule, right? Where all of a sudden we are opening up a member's ability to share their data with a bunch of third-party applications. And how do you ensure that the data is being used appropriately? How do you ensure that the member in this case knows enough and has the right information to share appropriately and not to just, give it out to just anybody they want? I think as Eric pointed out, VCI and this idea of a common standard is critical because, we do this. We've done this for decades, right? We're going to go solve a problem. Everyone's going to go solve it in their own way. And now we have like a dozen competing standards that no one can interoperate together. So I'm really glad, at least in this case, we've collapsed around a single standard. But then the other piece really is having those bits of education and having this very, very much controlled by the patient or by the member, right? This cannot be a corporate, it cannot be another entity. It's my data, it's my ability to control where my data goes, and given appropriate education, I should be able to share it in the way that makes sense. And I think if we take that as, again, another fundamental design principle of how a digital health record or a digital health pass could be used, that gives us that ability to say, yes, I will ensure that the privacy, the security of the data remains whole because it's in the hands of the person that should be sharing it in the first place.
Yeah, I mean, I think one of the challenges that we face here is a patchwork of rules. So how it's governed depends a lot on whether it's a health record. And if it's sort of created in the healthcare context, it's going to be covered with some set of rules. But if I download an app around mental health or around, ovulation or sexuality or around fitness or weight loss, or whatever, there's a totally different set of rules there. And that mismatch between the sort of regulatory oversight and sort of how a lot of really basic and pretty sensitive health records are being created, I talk about health information sort of more broadly, is something that is sort of outstripping the system. I would say sort of more broadly, the way you make a good system is to have pretty clear rules that everybody sort of understands and can follow. And I think we've made some progress on that in the digital health credentialing area, specifically with respect to pandemic response, but we do a pretty poor job of that overall, of having clear rules. Here's what you're allowed to do, here's what you're not allowed to do. The second thing you need to do is you need pretty good training for the people who are working in that system. So if you're talking about third-party applications, the folks who are coding the data need to sort of have a clear sense of what they're expected to do and not do. Say, very significant use limitations, those sorts of things. Privacy by design, minimization, these sorts of principles need to be taught. And then finally, there needs to be oversight. There needs to be accountability. People need to feel comfortable that when entities don't treat the data with respect, that it will be protected in a meaningful way. And we haven't done a great job of that. There's largely a system where very egregious violations get slammed at the end of the day, but very little effort to go way up the value stream and be proactive and tap people on the shoulder and say, actually, you really shouldn't be collecting precise data location from this user. You really shouldn't be sharing the identifiers with a third party here. We can see it and you shouldn't do it. And that just doesn't happen in our system. And so you either get whacked or you basically have a unaccountable system.
Yeah, and to close the loop on finance versus healthcare, if I lose my credit card, I can change my credit card number. If someone hacks my DNA, I'm not going to be able to change it.
There's been some very interesting, related to what you were just discussing, some interesting comments made in the chat that I think I'm going to tangent and bring into the conversation. A comment was made, what can we do to change the federal regulatory climate to be able to create this highway of data exchange? But a follow-up comment, which was interesting, which was, it shouldn't really necessarily be about federal or national. Now the pandemic has shown us how globally connected we are and how our health is so globally connected, especially with these biotypes of agents. So, my question for you all is, how do you create this superhighway of healthcare data exchange? We touched on this a little bit earlier. Do we need to think about it more globally? Is it a World Health Organization? Is it something else that's governing this pathway for us to share more data? The last thing I will add on to that is, we knew very early on that we got information about coronavirus maybe a little later than could have been helpful, and where we could have responded a little quicker and saved a lot of lives. So did we have that superhighway in place to be able to make sure there was some obligatory exchange of information? Threw a lot out there, but anybody want to jump on that?
You asked a hard question, Sunil. But it's interesting. There is at least the beginnings of that global interoperability in place between the standard that we've defined with VCI and some of the efforts that VCI, the folks in Europe and the EU and others, and with Green Passport, are saying, let's make these interoperable. The data formats themselves may not necessarily be unified, but at least there is that first level of, I will accept that national standard because that national standard is somewhat trustworthy. And I think there's, again, if we want to go and have the technical discussion about having a singular technology solution that spans the globe, I think we'll be here talking about that in 10 years. If we can have that at a regulatory or even just at a business level, if you can consider that as a business level, it's the start. And then that kind of gives you the ability to go up the stream or downstream, depending on which direction you're looking. So how do you make it truly more technologically interoperable?
Yeah, I think to me, it's 3 layers, right? You have a layer that says governments, states, and government entities will need to engage into that topic. If we wait for them to be ready on a global basis, to your point, it's going to take 10 years, maybe 20, maybe never. The next layer is the responsibility that we all have as technology firms and healthcare organizations to actually work on that together whether we have a regulatory landscape or not, by the way, but we need to work on that together. And we did that. VCI is a good example. We get the same in other places, in other countries. I think that's, a very important piece of the equation. And the last layer, which I think we need to spend a lot of time on in the next few years, is the consumer is going to demand this. Mm-hmm. That the change is going to come from the consumer. And even if there is no one at the regulatory government level or no one at the industry level pushing for something, the consumer is going to demand it more and more. The consumer, Sunil, to your point, going from California to New York, will not accept to get another CT scan for the exact same situation that he had in New York, in California. He's going to say, no, I already have this information. I'm not going to get a bunch of radiation again, right? And that's going to come from the consumer. I truly believe that. I think those are the three layers, the three levers we need to activate at the same time.
I think you bring up a great point about the consumer. What I will say, and then I think Quentin, you were going to say something, is one thing that we have seen in the, doesn't matter what insurance company you are and so on, and what payer you are, but we have about 50, depending on how you look at the data, about half the country gets their health insurance through their employer. Mm-hmm. And employers have gotten larger and larger over the last 5 to 10 years. We know there's a tremendous consolidation happening. And we know there are more and more employers are what's becoming called self-insured or self-funded. And what that basically means is the employer is saying, we will manage the costs of our own employees going forward. Insurance company, please help us get access to a provider network and do the paper transactional work with that provider. But we want to manage the risk of our employees by paying for it. What that has done is shift the cost of healthcare onto what you said, the employer and the consumer. And to your point, I think we will see more and more employers try to set the standards for data exchange for the healthcare and well-being, the preventive well-being, not the reactive well-being of their employees, because it costs them more money to be the reactive approach. So I think you bring up a very good point, and the financial reimbursement models seem to be moving in that direction as you get companies employing hundreds of thousands of people these days. Quentin, you were saying?
Yeah, so I want to make an optimistic point and a little bit of a critical one. The optimistic point is that I think we're in the very early days of personalized medicine. And if we look back on 2021, in 75 or 100 years, what we are doing now is going to seem really quaint. This is going to explode. It's going to be transformative in the ability to combat disease and population health. And so, yes, we need to get the rules right, and we need to get the structures right, because this is actually going to transform health and healthcare for generations to come. The pessimistic point is absolutely we need global rules. I worked for a law firm, and the client came to me and said, I want to do a worldwide product. And we literally hired law firms in 30 different countries to try and give a straight answer to the question of what you were allowed to do and not allowed to do. And that still meant we were guessing as to 150 countries. We've got a crazy system in terms of the rules of the road. But the pessimistic piece of this is that's not even the question, right? We can't get our act together here in the United States. We've been working on a Consumer Privacy Bill of Rights for more than a decade. It's not close to the finish line. California's made some progress recently, and they are sort of thinking more proactively about what does health data look like these days. It's very different from what it used to look like. But when we develop these systems state by state, when the FTC starts to think more seriously about new categories of health information, that's absolutely the right direction, but it does threaten to perpetuate this patchwork problem. So yes, we need a global standard, but frankly, Congress needs to get in the game. We need a baseline set of rules that cover the data that are increasingly being collected in these ways. And we need to give some certainty to practitioners and to industry and to consumers about what they have a right to expect. That's what it's going to take to create the kind of trust that makes these things work. Because like honestly, testing and tracing with digital tools didn't work, right? There was a window of time early in the pandemic where if we had been smarter about testing and tracing, where we could actually kept this thing into a much smaller kind of a problem. We didn't do that because we couldn't do that and we failed. And part of that is a system design flaw.
I agree. That super highway that you're describing didn't exist and resulted in, you're right. And while we heard about other countries that did have a systemic infrastructure for testing, vaccination, and so on, were able to contain things, markedly different than we could here for that reason. That's a great point. So we have about 5 minutes left. There's a lot of wonderful questions here in the Q&A. I will try to squeeze in one more, then I want to give you all an opportunity to kind of close with some remarks. But here's what I would ask. If we have struggled with a digital vaccine card, and I use the word struggle because, we like you pointed out, at a conference, somebody took a paper and you came in with a scan card, and we accepted both very easily and arbitrarily because something is better than nothing, right? I think that's the mentality, not the right way, but that was the mentality. Is what do you think if vaccine, I always say low-lying fruit, as complicated as healthcare is something we should all strive for. So a vaccine card was kind of low-lying fruit in some ways to be able to get it out the door and have some digital health credentialing solution. What do you think the other low-lying fruit could be? Somebody pointed out in the chat that mental health, substance abuse disorder, how can we track and monitor and share that information? That's difficult, especially since that's a sensitive area. What do you think are the low-lying fruit that could be next in line to potentially go after with a digital health credentialing type solution?
Post-COVID, I think we think about vaccinations more broadly, right? Because I think we all have that funny little yellow card that I don't know if anyone knows where theirs is. I don't know where mine is anymore. And I'm going to go take an international vacation at some point. I'm going to have to go dig it out. But I think vaccinations in general have been, no one thinks about them, but they're critical. They're critical for getting our kids in school. They're critical for certain jobs. When I worked in patient care, I couldn't walk out onto the floor without my flu sticker. And so there's still that need to go beyond COVID and say there's a broad set of data that we want to make available to consumers, to patients, to be able to share more broadly. And I'll tell you, this is probably the biggest reason we went down the path at Change Healthcare of creating this vaccination product. It took me 15 phone calls, faxes, and emails to get my daughter's vaccination information to her preschool. And it's 2020, man. I should click the share button somewhere and say, what state do you live in? California. Here's the pre-formatted Department of Health format. Off you go. So, but if I think about people working in patient care, food service, places where certain vaccinations are necessary, or even travel where certain vaccinations are necessary and need to be verifiable, I think that's kind of the real low-hanging fruit. After that, and I think, Eric, you made this point, or maybe Quentin, you did, it's about making the other health data that's important to your care easy to share, right? So whether it's, if you have a chronic disease, certain aspects of the data related to your chronic disease, like your A1Cs or your A1C history, if you're a diabetic, you don't have to have your whole medical records sitting on you. You have to have the information that's specific to your ability to get care that's necessary for you to share. And having a medically recognized, privacy secured way of doing that, I think is that next branch above the low-hanging fruit that we should be able to get to.
Great point. So
yeah. And Sunil, just I think to me the interesting piece is if you look at it, and especially for you, your physician, your doctor, when you see a patient today, most likely you don't have access to the entire spectrum of data that patient could have access to, right? Whether it's my medical device, wearables, 23andMe DNA, all of that. I do have access to this information myself if I want to, and I should be able to aggregate, share with you, and you can make better, faster decisions regarding my care. I think that's maybe not a low-hanging fruit. Low-hanging fruit, for sure it's not, but I think that's the long-term trajectory we really need to focus on.
Yeah, that's where I was going to go with this question as well, which is that, I wear a Fitbit, right? And it generates on a dashboard that I have access to lots of data that would be really helpful to my physician. And, on chronic disease management, for example, could be really, really helpful to monitoring care. And I don't, there's some niche ways in which that can be accessed. But for broad adoption, we should be able to share the data we're creating on a daily basis with physicians who can use it to help us manage our conditions, and especially for underserved populations, right? That's where you get at one of the largest drivers of the health equity problem. If you could use that on diabetes, obesity, depression, some of these categories in a real-time way, that would be really big.
All very excellent points. I want to take this chance, we're at 1:59, and I want to take this opportunity to thank my esteemed panelists. This has been actually a very worthwhile, and I've learned something from this conversation, and just the different perspectives have been incredibly helpful, and I hope the audience received the same. Sorry I could not go through all the questions this afternoon, but this could be a 3-hour discussion, we all know, with the current climate that we live in. So I want to thank everybody for being a part of this. Appreciate the panelists in the discussion, and look forward to the next one, and wish everybody well and a happy holiday as we get through the year. So thank you.
Thank you.
Thanks, everyone.